Pratik has joined?
No, sir.
Okay.
3, 2, 1. We are live. Please start.
Good evening.
Hello.
Sorry.
Yeah. So hello, a very good evening to everyone, and it's a pleasure to welcome you all for updates in lung cancer 2021. I think we are coming to the fag end of the year, saying goodbye. But before then, I think this is a very, very interesting session on the management of lung cancer. Now, to do the needful, we have a pleasure to welcome and invite Dr. Venkat sir, who is a consultant medical oncology at Assam Cancer Care Foundation. And so good evening, Dr. Venkat sir. We look forward for a brilliant discussion from you. Over to you for your talk, please.
Yeah. Good evening.
I think Dr. Pratik has just joined. So
Yeah.
can we intervene, sir? And
Sure.
can we request you to invite Dr. Pratik? Hello, Dr. Pratik. Good evening. Can you hear us, please?
Yes. Hello. Good evening.
Yeah. Thank you so much for joining. So we again invite Dr. Venkat to start the session with his welcome and introduction. So over to you, Dr. Venkat, sir. Over to you, sir.
Thank you, Taranji. So I welcome on behalf of Dr. Sajjan Rajpurohit, who is the convener for this Lung Cancer Updates 2021 in this December 2021. So regarding the I welcome all my colleagues, seniors, as well as my juniors and all the audience. So staying updated is not an option as far as lung cancer is concerned, because we have almost weekly to monthly updates, and there are new drug approvals and new conditions that are being approved for the same drugs. So a few years ago, we thought that NGS is very high-end diagnostic that is available only in cities and it done in only by apex institutions. But now it has become a way of diagnostic modality who are all practicing lung cancer. So to take through the role of NGS in the lung cancer, we have here our expert faculty, Dr. Pratik Chandrani, who is faculty and scientific officer in the Department of Medical Oncology, TMH Center for Computational Biology, ACTREC, Mumbai. Dr. Pratik Chandrani, I welcome you to talk on the topic of role of NGS in lung cancer. Over to you, sir.
Thank you, Dr. Venkat, Dr. Sajjan, and all the members of organizing committee for giving me this opportunity. Today, I'll be talking about role of NGS in clinical management and in clinical practice. So I'll be mostly presenting on one of my work, which I did during my postdoctoral research at that laboratory, a basic research laboratory at ECTREC, Navi Mumbai. And when I was working there as a postdoc just 1.5 or 2 years ago, we designed this computational solution for automated NGS data analysis and therapeutic inference. This was a work in collaboration between Dr. Amit Dutt and Dr. Kumar Prabhas. And I show here the purpose is to not only talk about how NGS is being used, but also to talk about certain challenges related to NGS data interpretation in the clinical practice, and how we can or one can get rid of those nuances and technical challenges. So to begin with, we all know that how cancer basic understanding has transformed from pre-1990s era, where most of the classification was anatomical and the therapeutic decision was also mainly governed by anatomical and surgical access to a cancer, to the era of 1990s and 2000s, where certain molecular biomarkers were used to classify cancer in more details, but the therapeutic regimen were still not targeting those biomarkers particularly. Rather, they were more broadly associated to different classes. To the coming 2010, post 2010 molecular classification era of cancer, where each of the individual molecule altered in a cancer cell mainly identified as a driver alteration. is being identified using next generation sequencing, and whichever driver alteration we detect, targeted drug has been designed and tested and proven to be active against those altered form of the proteins and genes. So that is where we are currently falling into, and that's where this presentation is also going to focus upon. So we all know what are the benefits of targeted therapy and how many different targeted drugs are coming into the market. We can see this upward trend since 2005. There is a very high rate of discovery of therapeutic targets, as indicated by blue line, as well as the drug compounds, as indicated by the red line. And we know they all perform very well in the clinics as well, as you can see here in this example of CML, where mortality rate, the red bar, goes down drastically after the introduction of imatinib, and further it goes down and down after every new generation of TKI, as can be seen after nilotinib as well. So in this, how exactly this NGS based interpretation of mutation is happening in the clinic. So we start with a patient sample, which is tissue biopsy, either obtained from solid tumor or liquid biopsy. And this biopsy sample goes to a next generation sequencer laboratory, diagnostic laboratory specialized into running the NGS machine and operating it. And the data coming out of the NGS machine is used for in silico analysis by computational biology team, and they generate the report of all the therapeutically relevant alterations. This report typically goes to a molecular tumor board. At Tata Memorial Center, we have a multi-disciplinary molecular tumor board, which includes clinicians, pathologists, molecular pathologists, basic biologists, the genomics expert, as well as bioinformatician. And these all people come together and discuss about the different aspects of NGS-based report, and finally make a decision on which therapy should be followed up for a particular patient. So in such kind of therapeutic stratification of the patient, what one is looking for is to identify as many therapeutic targets as possible. So that brings us to the next question, that how many different therapeutic targets we know till now, and how many are in clinical practice. So in this chart, what we are looking at is a theoretical knowledge of a therapeutic target in a particular cancer type, indicated by black arrow. And we can see these arrows go to very high values in certain cancer types, going well above 50%. But the clinical practice in the respective cancer type is not as prevalent as what we see by the black arrow. So clinical practice is indicated by the red dot. So you can see very easily that there is a huge gap between all the red dots and all the black arrows. So by and large, in all of the cancer types, we are far behind the theoretical knowledge of therapeutic targets in the respective cancer type. This is also independently shown by another study, which is a purely US, United States of America based study, wherein all the patients which walked into the hospital during the year of 2018 were included in the study. And out of all the patients, only 4.9% in practice received one or another TKI. And those TKIs are shown further in this blown up bar chart. But what one can easily see is that roughly about 95% of the total cancer patients in developed nation like USA does not undergo any precision medicine test, and they do not benefit from any regular precision medicine targeted therapy drug. So there is a huge gap in our theoretical knowledge and in practice, and we need to figure out why this gap exists and how we can fulfill this. So we sat down and we listed a few reasons which were playing role in this in creating this gap, and we started working upon it. So this presentation will show you one computational tool called Clinome, which stands for Clinical Genome, which has in-house knowledge base, a database consisting of therapeutic targets in 175 different genes all across the genome. As you can see here, over the whole of the human genome, each of the red bar indicates a therapeutic target existing at that particular location. So all of these genes harbor roughly about 3,000 different mutations, and each of these mutations corresponds to either sensitivity or resistance to roughly about 280 different pharmaceutical compounds. So there is a drug to gene ratio, variant to gene ratio relationship in the range of roughly about 25,000, which is a lot. So we know so many different therapeutic targets. We know so many different pharmaceutical compounds which can be potentially used in a clinical practice. So having our hands on this database, the next question we tried to address was to develop an in silico analysis module which can do this whole analysis task in a fairly automated manner, as well as in a less resource hungry manner. And we also identified a couple of challenges which are frequently faced during inference of therapeutics, and we tried to solve those challenges by using artificial intelligence, and in that way making our program much more smarter than the non AI driven tools which are existing in the world age of now. So the basic purpose of this Clinome tool is to identify variants of non-clinical significance and variants of unknown clinical significance. Now, the variants of unknown clinical significance are of no relevance to the clinic, so we simply remove them from reporting. And variants of non-clinical significance are further divided into various categories, and I'll show you some examples in the next slide. So here in this table, I'm showing one example wherein a patient of lung adenocarcinoma has been detected to harbor EGFR L858R and EGFR T790M, two different mutations in the baseline biopsy. So one can easily know that presence of T790M is indicative of resistance to first and second generation TKI. So obviously here third generation is the recommendation. So Clinome will give you this tabular output where it will show potentially effective drugs, and under this label it will show you US FDA approved drugs under the given settings. It will list out osimertinib, as well as it will give you the list of all the drugs which are reported to be ineffective, and they are not supposed to be used. So here you will find erlotinib, gefitinib, and apatinib listed out. So in this way, one gets to know about relevant therapeutics, as well as one gets to know about the therapies which are known to not be active in a particular mutation settings, and thus it helps a new clinician who might not be aware of all of this background story, and they need to be very clear that any of these three drugs should not be considered at all in this particular patient. In this another example, we are looking at a lung cancer patient harboring FGFR3 mutation, which is not a standard line of approved biomarker, and there is no standard line of therapy existing for this particular mutation in lung cancer. But Phenome will be able to give you some details regarding some of the drugs like BGJ398, which is under clinical trial for bladder cancer. And Clinome will also give you a hyperlink. So it's a HTML file. You can click on this NCT clinical trial ID, and you will be presented with details of the clinical trial, which is happening for FGFR3 mutated solid tumors. And now, if patient is willing to, and if clinician thinks that such kind of trial can really benefit this particular patient, then this trial can be recommended to the patient, and that can provide alternative options to the patient wherein the standard options does not exist. So that's the second case, and then we have third case here wherein we are looking at off-label recommendation. So here we have endometrial cancer patient harboring EGFR L858R mutation, a classical biomarker for showing response to any of the EGFR TKI. So in such kind of cases, Phenome will list out EGFR TKIs in US FDA approved off-label column. So clinician will know very well that these drugs, even though approved in some other cancer types for the same biomarker, but here cannot be directly used in the first line. But in some limited settings, it can be still useful if all the standard line of therapies are exhausted for a particular patient. And then we also have details regarding repurposed drugs, which are not again standard line of therapeutics, but this can be useful in certain resource limited settings where you can see here that EGFR LFITR is also known to show response to lidocaine, which is a very commonly available drug, although not recommended for cancer therapeutics. But having this information handy can be useful for a clinician researcher. So having these four different cancer type examples, which are all hypothetical cases, here what I'm showing is a real report generated from Clinome, from our in-house NGS diagnostic center. And we have de-identified all the patient-related details. So there is no detail available in the upper column where we generally list all the patient-related information. But in the below table, you will see exhaustive list of all the drugs which can be recommended for a particular patient, as well as you will see details regarding the NGS quality, basically detailing the gene-wise coverage and overall coverage to ensure that the whole NGS diagnostic test was done in the right way. So this is the real-world report generated from the Clinome. So, having looked at the report, now let me describe how exactly we are making sense of genomic data set in practice. So, this is the algorithm of Clinome, which encompass best practice of genomics data analysis, which includes primary, secondary, and tertiary level analysis. And all of these pipelines, which are in their own sense very exhaustive and generally demand a very high-end computer to do single sample analysis. So that entire pipeline is encompassed in these three different algorithmic steps shown by this red box. Now, parallel to that, we also require inputs regarding the cancer type. So, molecular pathologists generally provide this input for a particular patient, and there we see certain challenges wherein that a pathologist might, one pathologist might call a cancer type kidney renal cell carcinoma, and another pathologist might call the same cancer type but with different keywords, saying renal cell carcinoma extracted from the kidney tumor. So these two terminologies mean same to a trained clinician and in general to all the human. But for a computer, these two different keywords are entirely different. And if you try to match them with each other, computer program, a typical computer program will say that they do not match. So because of that, we thought of using a natural language processing algorithm, which is a part of artificial intelligence domain, to get rid of these anomalies. And this algorithm we have tested on 800, more than 800 different cancer types, and it does show remarkable matching criteria wherever we expect them to get rid of these linguistic anomalies. And so that's one part where we implement this AI to make better inference. Now this is being used to ask three specific questions: whether in this given cancer type a biomarker is known and reported to be the label. If not, then whether the same biomarker has been reported in any other cancer type, to consider any off-label recommendation. And still, if answer is no, then we look for all the registered clinical trials in NHT database. And if there is any ongoing clinical trial for a respective biomarker, then we pull out its detail and put it in the report. Now, downstream to these three different logical questions, we also have another AI module. We call it tumor type tree, or TQ, wherein we have a hierarchical classification of all the cancer types, and that can be very useful in the settings. Say, for example, there is a drug recommendation of TKI, EGFR TKI for non-small cell lung cancer. However, in today's world, all the pathologists prefer to directly classify lung cancer patient either as adenocarcinoma or squamous cell carcinoma. They no longer use the keyword non-small cell lung cancer. So if you want to match this non-small cell lung cancer recommendation label with lung adenocarcinoma, then a typical computer match will fail. So in this AI algorithm, what we have done is we have hierarchical classification wherein a computer program now knows that lung adenocarcinoma is a part of non-small cell lung cancer. So any drug which is approved for non-small cell lung cancer is automatically applicable to the child classification adenocarcinoma as well as squamous. And in the same way, in future, if there is a drug which is approved for in general for lung cancer, then the genome will be able to make the right inference. And one of the examples that I can give from the real world is NTRK. NTRK targeted therapies have been approved for all the solid tumors, and thus any kind of cancer type falling into the solid tumor tree hierarchical classification should be able to get this benefit. And Plenome is the only tool to our knowledge which has been able to pick up NTRK in different solid tumor test data set that we used, and it was able to give the right recommendation in that. So after following these three different logical questions, we generate the report either as a label, off-label, or a clinical trial, and then we put additional details in the report, which helps in the therapeutic decision making. So here I'm showing one demo of how the hierarchical classification in this AI tumor type tree algorithm has been implemented, and how AI algorithm travels through different parent-child relationship of these different cancer types. So having said that, it might seem much more complicated to a person who is not from the computational biology field. So we have some good news for you guys as well. We have developed a graphical user interface, a GUI. As you can see in this video screen grab, that I'm selecting certain options in the GUI, and based on those options, Plenome tool is doing analysis at the backend in the Linux system. So one need to learn the whole computational biology if they want to use the Plenome. It can be very conveniently used through the GUI, and one can also see that the report is generated just within few minutes, and it doesn't take much more resources to generate a Plenome report. And it is also much less resource hungry because of certain computational engineering concepts involved. So having talked about the Plenome basic tool, we have some more data from large cases based data analysis, wherein we are identifying several therapeutically relevant alterations which are under various clinical trial or preclinical stages. And you can see that majority of all the cancer types can receive benefit from these all therapeutics in near future. So that's a part of paper that we are planning to put it out soon, and much more detail will be coming out. So to summarize it, Plenome tool integrates a robust clinical NGS data analysis pipeline as well as a therapeutic inference pipeline in a easy to use tool set. And this tool set receives great benefit from artificial intelligence modules, which gets rid of technological and linguistic nuances, and that as I showed in practice, that can be very vital for different histopathological terminologies and different NTRK kind of therapeutic recommendations. Furthermore, we have observed that using Plenome, we were able to identify certain therapeutic targets which are already available in the market, as well as the targets which are under very active clinical research, and they might
Dr. Pratik, you muted yourself. Dr. Pratik, we can't hear you. Dr. Pratik Chandrani?
Hello.
Yeah, we lost you, Dr. Pratik.
Yes, so my apologies, my laptop battery died and I'm away from the office. So I right now I joined from the cell phone, but as we were already on the very last
Yeah.
slide of summarizing the presentation, so I can just continue with that for just one more minute and then I'll finish up. As we have seen, how clinome can be useful in the clinical practice, and we'll be publishing this paper will be out very soon. So we hope more and more people will be able to get benefit from such kind of technologies. And with that, I come to the very last part where I would like to acknowledge Dr. Amit Dutt, who provided fantastic support and guidance for development of this plenome, as well as Dr. Kumar Prabhas, a senior clinician from Tata Memorial, who provided very timely inputs for clinical inference and other developments in plenome. So thank you all once again. Thank you organizers for giving me opportunity to present this work.
Yeah. Thank you, Dr. Pratik. It's an excellent presentation on the nuance of the NGS and how where clinicians can go wrong and how to interpret it carefully, and particularly usage of artificial intelligence in the NGS platform. And we are definitely looking forward for the results of the studies you are doing ongoing in the TMH. So thank you for your time. So with this, we complete the first talk, and let's move on to the second talk. The speaker is myself, I am Dr. Venkat Pradeep. I am consultant medical oncologist at Assam Cancer Care Foundation, Tezpur. Today, I'm going to discuss about a osimertinib as standard of care with a real-world evidence. So, as a medical oncologist or any oncologist, so we look forward for the evidence in the form of phase 3 trial. And after the phase 3 trial is done, what we look really forward about is the real world evidence. So today, in this short time available, we are going to see what is the real world evidence about the osimertinib we have, and is it coinciding, or is it better than, or is it less than the phase 3 data, that is FLARA trial. We all know that in lung cancers, particularly which are mutation addicted, the targeted therapies in the form of TKs, they work better than chemotherapy. So we have osimertinib as a standard of care now, which is the best molecule available with us at this moment to treat EGFR mutation. And this is established as a standard of care by phase 3 randomized FLARA trial, where we have seen excellent improvement in both progression-free survival and overall survival. And progression-free survival improvement is really impressive in the form of 18.9 months compared to the 10.2 months with the previous standard of care. And same with the overall survival. So this is the final overall survival analysis of FLARA trial. And although we all know about the FLARA double-blind study design, I want to stress upon a few points before we move on to the real-world evidence. In the FLARA trial, the patients were in excellent performance status. So WHO ECOG performance status 0 or 1 was included. Also, there are only two types of mutations that were included in this trial. That is exon 19 and exon 21 mutations were included, but not the other two, like 18 or 20 mutations were excluded. Also, the CNS metastasis has to be stable to get enrolled in this trial. And both Asian and non-Asian population were included. I am discussing these points because these factors are a little bit different from the real world, where we see the mix and match of all these factors, and definitely there will be extremes of these factors. So we know the baseline characters of the FLARA trial, and PFS, we have discussed that osimertinib has benefited all the subgroups, may it be male or female, less than 65 or more than 65, Asian, non-Asian population, also smokers, non-smokers, and EGFR, whether it is positive by tissue biopsy or by circulating tumor DNA. So the benefit is seen across all the subsets, and it is really significant. And the same with the OS. And we know the conclusion, and that's why it became accepted as a preferred therapy because of its activity in the CNS. Also, it is preferred therapy in the EGFR mutation may be in the first line or even in the further studies. But as far as the first line is concerned, let us see the real world evidence of osimertinib in the form, which is available in the form of 3 studies. The first one is the FLOWER study. Second one is OC-FACT study. Third one is a MyCono study. What is really impressive about these studies is not only that they have seen the real world outcomes of osimertinib, so there are some newer endpoints that they have set for the future real world studies. So let us see. The first study is the FLOWER study. It is presented by Dr. Martina et al. And it is published in The Oncologist. So we know the background that why we need to have a real world studies, because in the clinical trial population, they do not actually represent the real world population. And it is seen that only 2 to 4% of actual cancer patients, they have access to the randomized clinical trials. So there is an issue of representativeness. That is the reason why we always search for the real world evidence. It is like we want to, when we want to buy a new vehicle, we want to know the mileage in the traffic conditions rather than in the ideal conditions declared by RI. So in the same way, real world data has become a useful tool to assess the unique insights into the routine oncological practice in the post-marketing setting. When we see the baseline features of the patients in this FLOWER study, the median age is 68 years, included geriatric population also, and there are 30% of patients who has brain metastasis. Both stage 4A, 4B patients were included. So one of the deviation from the inclusion criteria from the FLORA study is that here not only exon 19 and 21 is included, but also exon 18 and 20. All the 4 exons were included in this exon mutated population were included in this FLOWER study. When you see the endpoints, this is where the interesting part is. So there is a newer endpoint that is included in this study, that is MTTD, which is it's a real world endpoint which says that the time to treatment discontinuation, and the discontinuation may be of any cause. And this is the primary endpoint for this study. And the secondary endpoints are median overall survival, median PFS, overall response rate, and disease control rate. And one more point they have evaluated in the study is what is the time for diagnostic therapeutic pathway? That is the time frame between the diagnostic biopsy and the histological report. And out of all the diagnosed patients, how many patients have actually underwent local regional treatment, and what whether rebiopsy is performed at the time of progression. They have evaluated these points also. They have, in this study, they have evaluated the effectiveness in the poor performance status patients, in the patients with comorbidities, and even patients with rare EGFR mutations and active brain metastasis also. So these are all patients who were excluded from the FLORA trial. So they should be stable brain metastasis to be included in the FLORA trial. Rare mutations were excluded. So when we see the effectiveness of osimertinib in the real world, the time to treatment discontinuation, the median is 25.3 months, which is really impressive. And they have stratified and compared time to discontinuation for the patients with symptoms at presentation versus asymptomatic patients at presentation. For the patients who do not have any symptoms, the median time to discontinuation has not reached, means the patients are doing really well. And for those patients who are symptomatic at presentation, the median is 18.8 months. And the difference between 2 arms is really significant, which means that the patients, if they are asymptomatic, they are doing really well and quite for a long time while on osimertinib. In the same way, the other factor they have seen is patients with less than 3 metastatic sites and more than 3 metastatic sites. And they have seen that patients with less than 3 metastatic sites, sorry, they are mostly alloprogression, and they have used osimertinib for a long time in the real world, while undergoing local therapy for the local progression, while the patients with more than 3 metastatic sites, their median duration is only 21.4 months. For the patients with less than 3 metastatic sites, median is not yet reached, which means the patients are doing well. So this trial from this trial, it seems that time to treatment discontinuation is a more suitable endpoint to evaluate outcomes in the real world data. Also, we can see from the previous data which we have seen that patients with brain metastasis, patients who are symptomatic at presentation, patients who are having more than 3 metastatic site at diagnosis, they are faring relatively less well than those who are not. And coming to the primary assessment, the effectiveness, PFS. The median PFS is 18.9 months of all the whole cohort. And in the same way, patients with no brain metastasis, PFS median is not reached, whereas patient with brain metastasis, the PFS is only 13.3 months. We can see that with osimertinib, this is the least PFS we can see, and that is with the patients with brain metastasis. Even then, it is better than the first or second generation TKIs. Who have brain metastasis, although we do not have confirmed data. And coming to the patients with no symptoms, the median PFS has not yet reached, and for the patients with symptoms, it is 15.5 months. So also they have seen the real-world diagnostic therapeutic pathway, which we have discussed, and nearly 50% of patients, they underwent rebiopsy at progression, out of which 2/3 of patients underwent tissue rebiopsy, 1/3 of patients underwent liquid biopsy. And they also done a molecular analysis at progression in nearly 60% of patients. And they have seen that there are some druggable resistant mechanisms even after the usage of osimertinib, some of which are meta-amplification and EGFR amplification and HER2 amplification. Obviously, for the drug targets are available, drugs are available. When we see the real world safety data, one of the most concerning point, obviously we know that is pneumonitis. However, it accounted for only for 2.5% of cases which are grade 3 or grade 4. Other important side effect which is higher in incidence is venous thromboembolism. Also, pulmonary thromboembolism is noted in patients who are treated with osimertinib. So this is one point, and that we should keep in our mind while we are prescribing osimertinib. Although the rash incidence is quite less compared to the first and second gen, it is 1.6%, which is significantly low, and dry skin is almost 0%, and paranoia are seen in 0.8%, which is grade 3 or grade 4. So it is also seen that this venous thromboembolism is independent of patient's performance status, comorbidity, or tumor load. So it is due to the drug-related side effect. Let us move on to the second trial of real-world evidence, that is OCFACT.
Sir, sorry for intervening. You need to conclude in 1 minute, sir. Sorry.
Yeah. So here the patient population is almost similar. The study endpoints, it tried to treatment failure. So here the PFS is 20.5 months. And when we see the conclusion of this study, it has done really well, as almost similar to the FLORA trial, and side effects are almost similar to the FLOWER trial. But the pneumonitis, which is nearly 4% in this study, needs further investigation, because we are using to treat lung cancer, and pneumonitis is the most important side effect, along with the venous thromboembolism. Coming to the final study of osimertinib real-world data, I will conclude with these 2 points where they have used a new endpoint, which is time to new treatment or death. So due to any cause, and it was 17.9 months in this study, and 18.4% have died while on osimertinib, and 18.8% switched to the second line, while the remaining patients has continued to use osimertinib. Also, in the multivariate analysis, it is seen that stage at initial diagnosis, smoking status, and elderly people were included. So Charleston comorbidity index greater than 3 and number of metastases more than 4, they have done really well, and they have less time to new treatment or time to death. In the same way, time to discontinuation is also related with the same factors. So these are the take-home messages. So these real-world insights gave a hope that we can rely on osimertinib, just like we have relied till now based upon the phase 3 data. So with this, I thank you and conclude my session. Because of the time constraint, let's move on to the session by Dr. Divesh Goyal, following which we shall have the panel discussion by Dr. Sajjan Rajpurohit. I invite Dr. Divesh Goyal, Senior Consultant, Fortis Hospital, Jaipur, to discuss on lorlatinib, whether to use it in the first line or second line. Dr. Divesh Goyal, over to you.
Thank you. I'm audible.
You are audible.
Yeah, my screen is visible.
Please make it a full screen.
Yeah. Thank you. Thanks, Dr. Sajjan and all team for giving me today opportunity. And today, just we will discuss on this lorlatinib, first line versus second line in this ALK positive advanced non-small cell lung cancer. So the flow of discussion is going on this various pathway. So as we know that the first ALK positive ALK against the ALK, the crizotinib was accelerated approval in the 2011. Following this, the ceritinib, alectinib, brigatinib, as well as the lorlatinib, and now further encertinib. So in 2021, in 2018, the lorlatinib was accelerated approval, and in 2021, the first line approval was also done. So as we seen in this, the journey, there is approval of various molecules in this ALK positive. Initially, only crizotinib is available. Following this, ceritinib, alectinib, lorlatinib, and brigatinib nowadays available. So the CROWN trial, in this, the article was published in this NEJM, first line lorlatinib or crizotinib in advanced ALK positive lung cancer. So the study design in this stage 3B or 4 ALK positive non-small cell lung cancer and no prior chemotherapy, as well as asymptomatic, treated or untreated CNS mets was permitted. So 1:1 randomized between lorlatinib 100 milligram daily and the crizotinib, the 250 milligram twice a day. So the primary endpoint was the PFS and secondary endpoint PFS by investigator, overall response rate, intracranial overall response rate, duration of response, and the time to progression, as well as overall survival, safety, and quality of life. So as we shown in this graph, the PFS by the BICR analysis, the central reviews, at the 12 months, the PFS is 78% versus the 39% for crizotinib. So we see that the curve is separated earlier, and so the better for this the lorlatinib. So median PFS is still not reached compared to the 9.34 crizotinib. So as we shown in this subgroup analysis, the whole patients, the presence of brain mets, ethnic origin, EPOC, sex, age, so all in these indications, the lorlatinib better. But if the presence of brain mets, then it definitely better compared with without brain mets. And in non-Asians compared to the Asians works better. And smoking status, if there is never smoker, they works better compared to the current or former smoker. And adenocarcinoma only works. So if we seen in this overall response rate, so the responders is the 76% compared to the crizotinib is 58%. So overall complete response were in 3% versus 0, partial response 73 versus 58, and so median duration of response, so this is not reached compared to the 11 months for this crizotinib. So median time to response is the similar 1.8 months for both lorlatinib as well as crizotinib. So intracranial overall response rate, so 66% for the lorlatinib in this patient whose measurable or non-measurable brain metastasis at baseline, compared to the 20%, and if measurable brain mets at baseline, so 82% versus the 23%. So it better works in presence of brain metastasis. Again, the median duration of response in lorlatinib is not reached compared to the 9.4 months in this crizotinib arm. So the time to progression, so it will further delay the intracranial progression, the lorlatinib, as we shown in this graph. So the median time to CNS progression, again in this lorlatinib, is not reached compared to the 16.6 months in this crizotinib arm. So it definitely works in presence of brain mets, and it still delay the intracranial time to progression. So as we shown in this OS data, so in this both the graph, they will still, there is not reached. Obviously, the OS data is similar. So the median treatment duration in this lorlatinib, it again not reached compared to the 9.6 months in this the crizotinib arm, and the any grade of events are comparatively 3 or 4 or serious adverse events are comparatively higher in the lorlatinib arm compared with this crizotinib, but it is well manageable. So adverse effects are most common: hypercholesterolemia, hypertriglyceridemia, and edema is more common, and the mood effects. So as we shown in this graph, there is other various side effects. And the conclusion of this Crown study that lorlatinib resulted in this significantly longer PFS, significantly higher overall as well as intracranial response rate, and improved global quality of life compared to the crizotinib in first-line treatment naive ALK positive NSCLC. And safety profile was also similar to that reported in this previous study. So the grade 3 or 4 events were more frequent with this lorlatinib, but majority were laboratory abnormalities that were asymptomatic and readily manageable. So these results supports the use of this lorlatinib as an effective first-line therapy for patients with advanced ALK positive non-small cell lung cancer. So now second-line lorlatinib in clinical data in the phase 1 study and following this phase 2. So the phase 2, the comparative data. So the primary endpoint were the overall versus and intracranial objective response rate. So as shown in this, prior crizotinib plus chemotherapy or prior non-crizotinib and 2 or more than prior ALK TKIs. So in their overall response rate is, if there is only and only prior crizotinib, 72.9% versus the if there is prior non-crizotinib 42.9, and the if 2 or more than prior ALK TKIs then 39.6. So it will works in sequential pattern. If there is crizotinib is used initial, so there is response is much better compared with this non-crizotinib and other 2 or more than TKIs. So if it will still works, but effects is comparatively lesser. So the duration of response again not reached compared with this 5.6 and 9.9. So the intracranial efficacy, if prior crizotinib, only crizotinib, then 70.3 versus the 46.2 in non-crizotinib ALK, and 2 or more than 2 prior ALK TKI is the 48.1. So in both arms, the duration of IC response were not reached compared with this 14.5 months in this 2 or more than prior ALK TKIs. So the duration of intracranial response in months not reached compared with this 12.4. So this translational outcome of this study that of 190 baseline plasma sample in pre-treated ALK positive patient, 24% had more than one or more than detectable ALK kinase domain mutation. So almost 27 unique mutations were detected, and G1202R deletion was the most frequently observed, 25%. And in this, without a detectable ALK mutation, the 63% responded to the lorlatinib. So the therapy-related adverse effect are slightly more common with this lorlatinib, and the discontinuation rate, the slightly better, and grade leading to the dose interruptions or reduction in up to 2% of patients. So the conclusion of this study that showed lorlatinib showed clinically meaningful benefit in pre-treated patients with ALK positive NSCLC, including those who had received only prior crizotinib, only 1 second generation ALK TKIs, or up to 3 prior ALK TKIs. So this also showed a promising activity in TKI naive patient with ALK positive NSCLC. So anti-tumor activity was also seen across a variety of ALK kinase domain resistant mutation, including the G1202R deletion mutation, and response were also observed in patient without detectable ALK kinase domain mutation. So this was fairly tolerable, low incidence of permanent discontinuation, and due to therapy-related effects, and that were manageable through dose modification or supportive therapy. So how can we overcome resistance to the approved next generation ALK TKIs? In this shown this, there is various second generation TKIs, the various mutations develop, various resistant mechanism can be developed on ALK mutated agents. So acquired resistance to these ALK inhibitors remains a major challenge, and sequentially ALK TKI therapies can give rise to the compound ALK resistant mutations, several of which are refractory to all approved ALK TKIs. So ALK independent resistant mechanisms are common after the potent ALK TKIs like lorlatinib. So sometimes ALK dependent or sometimes ALK independent. So the sequential third generation of ALK TKI, initially crizotinib followed by the alectinib and lorlatinib. So there is the double mutations were achieved. So on this, more generation of ALK TKIs were sequenced, the more monster ALK resistant mutations were appeared. So the lorlatinib almost covered the broadest range of ALK resistant mutation and almost including the ALK G1202R12. So ALK positive patient also developed compound mutation upon sequential treatment with ALK inhibitors. So what is the rationale for upfront use for this pan-inhibitory agents? So this lorlatinib suppressed the emergence of single ALK resistant mutation, and upfront lorlatinib could significantly delay or suppress the on-target resistance. So this article, a systemic review, was also published in this comparative efficacy and safety of lorlatinib and alectinib for ALK rearrangement positive advanced NSCLC in Asian versus non-Asian patients, systemic review. So in this, the summary was the overall participants group, the efficacy of lorlatinib and alectinib was not significantly different in terms of PFS and OS. So almost same, but in Asian subgroups, PFS was not significantly different upon treatment with this lorlatinib or alectinib. And in the non-Asian subgroups, PFS was significantly better in response to lorlatinib than with alectinib, and grade 3 or higher adverse event in this overall participants group were significantly more frequent with lorlatinib than with alectinib. So the subgroup with CNS metastasis, no significant difference were observed between lorlatinib as well as alectinib, but PFS was significantly higher in patient treated with lorlatinib than in patient treated with this chemotherapy, crizotinib and ceritinib. So the NCCN guidelines also recommend this in case of ALK rearrangement positive. So alectinib, brigatinib and lorlatinib are now, it is the category 1 indication. Thank you.
आपको आईटी वाले को व्हाट्सएप कर दिया सरकार ने सचा
Dr. Venkat, you there or?
Yes, sir, I'm here.
Oh, yeah, so I'm also here. I'm so sorry. I apologize for being slightly late here because there was a prior commitment. So
no problem, sir. So for the next session, we shall move on to the panel discussion. I would like to invite Director BLK and Max Super Specialty Hospital, Dr. Sajjan Zoid, to start with the panel discussion. Welcome, sir. Over to you.
Thank you, Dr. Venkat, and for co-hosting this meeting with me. So I'd like to invite, so the esteemed panelists for today's evening meeting are Dr. Priya Ishuk-Muniani. Dr. Priya, your name appears as if like you are from Bollywood. So are you from Bollywood? Your name is double P-R-R-I-Y-A. So she is...
No, my name is P-R-R-I-Y-A. Double P double R पता नहीं क्या लिख देते हैं लेकिन it is P-R-R-I-Y-A.
So she is surgical oncologist at Asian Cancer Institute, Mumbai. Dr. Riya Shah, she is from Institute of Pulmonary Medicine Research and Development, Lung Care and Sleep Center. Dr. Satvik Khader, I'm so sorry with pronunciations. Dr. Satvik Khader, Consultant Medical Oncology, Oncomics Cancer Center, Ahmedabad. And also our esteemed speaker before me, Dr. Divish Goyal, my friend. He's a senior medical oncologist from Fortis Hospital, Jaipur. And Dr. Preetam Kataria, she consultant, Sir HN Reliance Hospital, Mumbai. So with this, welcome all the panelists. And right away, we'll start with the panel discussion. So this is a discussion on the early stage lung cancer and how we can improve the outcomes in lung cancer. So can we have the next slide, the case presentation? So going right away to the case. So this is a 67-year-old gentleman, non-smoker, presented with mild cough. Chest X-ray shows small lesion in the left upper lobe. CT scan shows lesion in the left apical lobe. Next slide, please. So this was the imaging. So PET scan showed that there's a nodular opacity in the left upper zone. Next slide. Next slide. Okay. So here. So this was the PET the CT scan findings. The PET scan finding, which was a intense FDG with well-defined lobulated soft tissue nodular lesion in the apical posterior segment in the left upper lobe with adjacent pleural tag. And there was also some non-avid prevascular lymph nodes, likely reactive, and no other evidence of disease anywhere in the body. Next slide, please. So my question to Dr. Divish, I will start with you first, sir.
Yes.
Is a CT scan guided biopsy possible for such lesions? And also comments on tumor quantity which might enable molecular testing.
I think this case I will discuss to my interventional pulmonologist as well as interventional radiologist.
Okay.
I think the upper lobe lesion, I think this is the biopsy-able. So CT guided biopsy can be done.
Okay.
In my opinion. And I think the tissue is required in sufficient quantity so that further molecular testing can be done on these slides as well as blocks. So I think CT guided biopsy can be done if my intervention radiologist is comfortable, and next the tissue is required in sufficient quantity for further testing.
Okay. Okay. So to the surgeon. So Dr. Priya, for such lesions, if the brain is normal, brain evaluation is normal. So if the patient comes to you, what do you do?
I'll actually get a CT scan guided biopsy done. If the plan for this patient as per now is upfront surgery, because it's a very small peripheral lesion. I think it's T1B, T1C. So that requires a multidisciplinary tumor board, whether it requires a mediastinal staging or not. Because anything above T1C, we do it. So if I can get the size and all that better on your report, I'll be able to tell. But right now, I will plan a upfront left upper lobectomy. So when I do a CT guided biopsy, I will not do the molecular markers, because anyways I'm doing the surgery, so that entire specimen can then go for the markers, which is definitely better in quantity.
Okay. Okay. So the surgeons feel that upfront surgery is possible. Yes. If the such patient come to surgeons, mostly they go for evaluation, and normally they the patient ends up with a upfront surgery, and then based upon the histology, the further treatment goes away. So any difference of opinion, Dr. Preetham? Is there something which you'd like to add for such patient?
No, I agree with the surgeon that first we'll go for a sort of a CT guided biopsy, and then if this is since it looks like an operable lesion, we'll go for an upfront surgery and then subject the whole specimen based on the histopathology for the complete molecular profiling.
Okay. So Dr. Satvik, how much tissue is enough for especially for your molecular oncology test? What is the kind of tissue we're looking at?
Yeah, so definitely we need ample amount of tissue, and at least 100 tumor cells should be if we are doing PD-L1 testing, so at least 100 tumor cells should be there. And also for DNA testing, we need a good amount of tissue. So surgical excision would be surgical specimen would be the best.
Okay, surgical specimen is best. Okay, go to the next slide, please. Next slide. Can we move to the next slide? No, next slide, not the previous one. So there was a CT scan guided biopsy which was done, and it was adenocarcinoma. And I'll start with Dr. Ria. Dr. Ria, staging. What do you do for staging for your patients who are localized patients? So what are the important aspects of your staging in such patients?
So even though especially coming to this patient, even though the PET is not showing any uptake in the nodes, we do see, and studies have also previously shown that T1 lesions may have some occult malignancy in the nodes. So staging EBIS should be probably done even in these kind of patients. That's what we try to practice in our center.
Very nice. I think I will take opinion of Dr. Priya. So staging mediastinoscopy or EBIS, what do you prefer, or you will rely on the PET scan?
No, we prefer EBIS. What I agree with what the lady has said, that I also prefer to do it in most of the cases. The only thing is that it's a T1B. Anything above T1C, definitely we do it. If it's T1A or T1B, and if it's a very peripherally located lesion, we see very rare occult N2. So if it's N1, anyways, the surgery is still the mode of treatment. And nowadays, even if it's a small single station N2, upfront surgeries are being also proven to be adequate. So yes, I agree. It depends on your MDT, your institute policy. If it's a T1A, B, C, T1A or B lesion, I would probably just go ahead with the PET and an MRI brain, which I do for all. And if it's a T1C above, I do a EBUS. We prefer EBUS, and the results are quite. The yield is quite good now. But it will go through my MDT definitely.
Okay, I think very valid point by all the panelists. So we move on. Next slide. Can we just scroll it? Okay, just hold it here. Just to go back. Yeah. So now the NCCN guidelines will show that PFT is obviously bronchoscopy if required, because many of us are not skipping bronchoscopies. So what bronchoscopies do add in peripheral lesions? Do they add some information? Dr. Ria, would you like to go for bronchoscopy? Are there something additional finding which we can find on bronchoscopy?
Really, in these kind of peripheral lesions, very rarely any involvement may be there. Even if the nodes, see in EBUS, obviously a flexible bronchoscopy is done. So, that is combined already. But especially separately, bronchoscopy.
Okay. The other thing which has been mentioned is pathological mediastinal lymph node evaluation, which refers to in most settings EBUS, but yes, in some settings we might require mediastinoscopy, a PET scan, MRI brain. Again, they have said in 1B it might be optional, but most of us end up getting a brain evaluation before we go for surgery. So next slide, please. Next slide. Please scroll down the slides. We go to the next slides. Okay.
Hello, sister को बुलाओ ना. Sister बोला, लवकर बोलो.
Okay. So Dr. Priya. Okay. Dr. Priya. So I think we already discussed this thing.
Yeah,
so can in T1 lesions we can skip? You said we can skip T1 lesions. Is there any difference of opinion from any of my panelists? T1 lesions, peripheral lesions, could we skip? Dr. Devesh, any thoughts?
I think I have not seen any T1 patient.
It's a good one. Your medical oncologists don't end up seeing them. The surgical oncologists, they just clear them and then. Okay. Yeah. Okay. Next slide, please. Next slide. Let's keep moving. Please go to the next slide. So, yeah, EUS was done. There were no mediastinal nodes, medically fit, underwent surgery. Next slide. So the final histopathology report actually came was PT2N1. So this was a report which came in finally. So the size of the lesion was slightly bigger, and it was, why they've written PT21? I don't know. According to the AGCC 8th edition, the histopathology was probably PT2N1. Okay. So now coming to this, Dr. Priya, are you getting reflex molecular testing at your center for such patients?
No, it's not reflex. It is decided by the surgeon, but as an institute protocol, we have different surgeons. One of them prefers to do it. One of them does not prefer to do it reflexively, like immediately post-op. So it depends on the surgeon. We tell the pathologist, we write a form, and if that is done, then it is done definitely.
Dr. Satvik, if your surgical colleagues ask you, what would you like to send for the specimen? So what would be your answer for such patient?
So if the decision of the MDT is to send molecular testing, then I would go for EGFR testing in patients.
Okay, EGFR. Dr. Devesh, your surgeon is calling you.
Yes. So my preference is to go EGFR.
EGFR. Okay. Yeah. So Dr. Preetham,
only EGFR testing.
Only EGFR. Very nice. So yeah, I would agree with you that most of us are not getting extensive testing at the upfront setting because they are not of any clinical relevance except for EGFR. But yes, in today's world, EGFR is an important aspect of testing. Next slide. Next slide. So are you aware of any Indian data on EGFR prevalence in early lung cancer? Dr. Devish, any data, any published data from India?
Actually, I have no idea, but data will showing that 30 to 40% of patients may be EGFR positive in the early lung cancer, because the Indians or Asian subgroups have more and more EGFR tendency. So I think 30 to 40% of patients may be EGFR positive.
So, Dr. Ria, is it possible that early lung cancer might have a different profile, or they are similar to the later patients where we get it in advanced stages? So, is there a discrepancy in the EGFR expression? What is your take?
There's a big discrepancy in early or late stage, which has been called the EGFR mutation.
Okay. Next slide. So we have some data, so we don't have much Indian data, but what the Western data has shown is that it is quite similar. So almost, I would say it is almost similar to the metastatic setting. So the prevalence of EGFR continues to be similar instance, whether it's stage 1, 2, 3, or 4. So that's kind of a data. And yes, I agree with Dr. Devish that with the Asian population, the incidence is higher compared to the Western population. Next slide. So this we already answered, NGS versus EGFR, if NGS, why? So would anybody like to take this question, NGS, why? Is any of you interested in NGS, Dr. Preetham? Would you be more happy with NGS or EGFR?
Well, in this particular patient, I would be more happy with doing only EGFR, because in adjuvant setting only I have a data for osimertinib for EGFR, directed therapy. NGS, I would a little refrain because it won't be adding too much to my treatment decision making at this point.
70 ml per hour fluid chalega na isko? 70-75.
Okay, next slide, please. Dr. Priya, thank you so much. You are doing clinical work together with handling this panel discussion.
I landed up posting a surgery, unfortunately, at the same time.
No. We can
frozen section was not available before this, so I tried to fit in the frozen.
No, absolutely fine. We are loving it actually. You're on the section.
I hope I'm not too audible there. I'm keeping it.
You are audible in it, but that's fine. That is making the things.
Shit, that's sad. I'm so sorry.
No, that's fine. It's fine. Okay. Okay, we move ahead. So this patient was stage 2 adenocarcinoma, and the patient was found to have EGFR L858R on. There was a molecular panel which was done, unfortunately, but we normally don't do a complete molecular profiling at this stage. So now I'll come to Dr. Devish. Chemotherapy, osimertinib, chemotherapy followed by osimertinib, or any other combination. Well, if a patient is diagnosed, surgeon sends the sample right away. They involve you in the MDT. You say EGFR. By the time patient is recovering, patient comes with this report to you. What do you do?
Yes. So my take on this patient, in this patient, so further chemotherapy, radiotherapy followed by the further adjuvant osimertinib. So first CTRT, then osimertinib.
So Dr. Devish, CTRT. Dr. Preetham, any difference of thought for this patient? Dr. Preetham, you're on mute. You're on mute. You have to unmute yourself.
So it's a stage 2 disease, right? And so I would, there's a data which says that adjuvant osimertinib from stage 1B and above can be considered in this subset of patients. So I would sort of play my safe game with osimertinib in this kind of patients. Yeah.
That's very nice. So you would like to suggest this patient only to osimertinib. Dr. Satvik, your take on this patient?
Yeah, so definitely I would like to go with chemotherapy and then explain the patient about osimertinib and its only DFS benefit. I would not like to omit chemotherapy because that has a long proven record of benefit and as compared to osimertinib. So definitely I'll go with chemotherapy and then I'll explain the patient about the pros and cons of adjuvant osimertinib post.
Dr. Ria, any difference of opinion from the previous panelist?
Sorry, this is beyond my scope.
Okay. Thank you so much, ma'am. So I'm not calling in Dr. Priya because she'll say, what are you engaging me in? So I'll just have
Honestly,
my
that's right.
Thank you, ma'am. So what my take has been because of the first line data on osimertinib. Though there was a subset which was subjected to chemotherapy, almost 60% patients had received chemotherapy and then subjected to osimertinib, and there was a trend towards detriment in survival with the addition of chemotherapy prior to osimertinib. So in fact, patients who are likely to benefit from anti-EGFR therapies, if they are subjected upfront to osimertinib, probably they might have a better role. But yes, if both the approaches are used, probably chemotherapy followed by at the end of completion of chemotherapy to osimertinib, or osimertinib upfront, both are appropriate. But yes, a subset analysis which was done showed that these patients might benefit from upfront anti-EGFR in the adjuvant setting. Next slide, please. Next slide. So I'll just skip this because we are running short. We have LACE meta-analysis. We know that there's an adjuvant chemotherapy benefit starting from 1B onwards. This we all discussed. Next slide, please. Next slide. So this is the landmark trial which has changed, which has been practice changing. It's an ADURA trial, adjuvant osimertinib and EGFR mutation positive early non-small cell lung cancer. Next slide. Next slide. I just rushed through this. So based upon this, osimertinib versus placebo. Next slide. The patients were and you can see a huge difference in the curves. So this kind of curves are like landmark trials where if you just see the primary population did not have 1B, they had 2 and 3A, but even in the extended population which had 1B, there was a difference of the primary endpoint was disease-free survival. There was a huge difference. So not reach versus 19.6 months in the intention to treat population, in the primary population, and in the OTT there was again, and the difference was osimertinib was not reached, and hazard ratio was 0.17 or 0.20. This means that this is a landmark trial. Next slide. So there were other trials with other drugs, but none of these trials could have such benefit and clear demarcation of the curves, and that too happening right till the follow-up. The difference in the curves kept separating till the follow-up of around more than 36 months. Next slide. Next slide. So 11% of patients in the osimertinib arms had DFS events compared to 40, almost more than 4 times patient had disease recurrence happening in the placebo arm compared to only 11% patients having disease recurrence till the time patients were being followed up. That means there was a huge significant difference in the disease-free survival in the patient who were subjected to early osimertinib. Next slide. So I just ask because in the paucity of time, because we are running short of time. So one question from all the panelists. So do you think that in the light of this data, is adjuvant osimertinib a new standard of care? So I'll start with Dr. Priya. Just yes or no, ma'am, and then I'll leave you.
Yes, it is. It's definitely looking very positive. I've been going through the paper. It's actually very nice.
Yeah. Thank you so much, ma'am. Dr. Ria?
Yes, absolutely.
Yeah. Dr. Satwik?
Yeah, sure. Absolutely.
And Dr. Preetham?
Yeah, definitely. I think a landmark paper.
And Dr. Devesh?
Yes, definitely. But one point, if financially affordable.
Very nice. So it's a very valid point. If for Indian patients, we would love to have osimertinib more and more. We'll request the company people to make it more accessible and affordable. But if it is available to us, even for early stage lung cancer patients, it can be a landmark and a life-changing drug for them. So with this, I'd like to stop the panel discussion here and thank you all the panelists for joining today evening for this evening symposium. And we are back to the meeting. Thank you so much. Thank you so much.
Thank you very much.
Thank you.
I'm really sorry I was not mute in the middle.
No, ma'am. No, it was no problems, ma'am. Thank you so much, ma'am. Thank you so much.
Thank you.
With this, we like to move ahead. And Dr. Venkat, you're there. If you could help me with Dr. Venkat, if you're there. Dr. Venkat is not there. So what I'll do is, so next topic is will be presented by Dr. Venugopal Aruja from Hyderabad, and he'll be speaking on a role of alectinib in the first line setting in non-small cell lung cancer, which is EGF, this ALK positive.
Yeah, hi. Very good evening. I thank the organizers for giving me this opportunity. So just let me share my screen. Hello?
Yes, sir. You're audible and the slides are visible.
Yeah, yeah. So I'll be talking about role of alectinib in first-line ALK positive NSCLC patients. So basically, if we look at the incidence of ALK positive NSCLC, it is almost relatively uniform across ethnicities. So Europe, it's around 3.7% incidence, US around 8%, and East Asia around 3.4% incidence. And as we know, the incidence of ALK positive NSCLC is higher in patients with non-squamous histology, never are former smokers, younger patients, females, and patients who do not have EGFR or KRAS mutations. So we'll be just rushing through the data for crizotinib, ceritinib, as well as alectinib. Then we'll discuss what are the differences between the molecules in terms of CNS efficacy and overall efficacy. So the profile 1014 data, as we know, it's a randomized multicentric phase 3 open label study of first-line crizotinib versus chemo in ALK positive NSCLC. So where the primary endpoint was PFS, so patients were randomized to receive crizotinib versus PEMSIS or PEM-carbo. The primary endpoint PFS. So the PFS with crizotinib was 10.9 months versus 7 months with the chemotherapy. So where it was statistically significant in terms of PFS. And when you look at the final primary OS analysis, so the median OS was not with crizotinib versus 47.5 months with chemo, and 4-year OS rates are crizotinib 56.6% versus 49% in chemo, hazards being 0.760. And if you look at the summary of adverse events, the frequency of vision disorders and grade 3, grade 4 elevated transaminases definitely was higher with crizotinib when compared to the chemotherapy. So what are the basic crizotinib resistance mechanism in any ALK positive disease? So in around 30% of the patients, the mechanisms of resistance are unknown. And the later is secondary ALK mutations. They have been identified. So these mutations, secondary ALK mutations, can promote the resistance by increasing the ALK affinity for ATP. And therefore, they increase the resistance by increasing ALK affinity for ATP, therefore reducing the crizotinib binding. Next comes the ALK copy number gain. It is an increase in the number of copies of EML4 ALK rearrangement. This is either an increase in the number of copies of rearrangement per cell or more cells displaying the rearrangement. And next, alternative driver oncogen mutations like EGFR mutation, KRAS mutations. So altogether, they contribute to the crizotinib resistance in the ALK positive disease when the patient is kept on the crizotinib. So next comes the molecule ceritinib. So this data is from ASCENT-4 trial. It's a phase 3 first-line ALK positive NSCLC. So where the patients were randomized to receive ceritinib 750 mg per day versus PEMSIS or PEM-carbo, followed by PEM maintenance. The primary endpoint was PFS. Again, the primary endpoint PFS with ceritinib is 16.6 months versus 8 months with the chemotherapy. Hazards being 0.55, p-value is very significant. But one argument was chemotherapy is not the standard of care in the setting. So ASCENT-4 PFS subgroups, if you look in the patient without brain mets at baseline, the ceritinib has got median PFS around 26.3 months, and in the patient with brain mets, 10.7 months with ceritinib. So again, generally the rates of toxicity were similar for both ceritinib and chemotherapy. However, the percentage of dose adjustments were higher for the ceritinib, especially higher rates of GI toxicity and the liver enzyme elevations. So GI toxicity, in particular diarrhea, nausea, vomiting, they were reported as worse for ceritinib than the chemotherapy. So let us have a look in terms of CNS blood-brain penetration, blood-brain barrier penetration and CNS efficacy. So basically, usually the drugs enter the brain by crossing the blood-brain barrier, as we know. But the blood-brain barrier contains drug efflux transporter proteins like P-glycoprotein and breast cancer resistance proteins. So these transporters, basically, they eject the drugs out of the blood-brain barrier through active efflux before they cross into the CNS. So crizotinib is a substrate for P-glycoprotein, and ceritinib is a substrate for both P-glycoprotein as well as BCRP, whereas our alectinib is not a substrate for any of these. So the CNS exposure of crizotinib and ceritinib may therefore be inadequate to control the disease in this CNS location, and the CNS forms the sanctuary site for the tumor growth. So if you look at the CNS as the first site of progression, 46% of the patients treated with crizotinib and 40% of the patients treated with seratinib, they have the CNS as the first site of progression. So this actually the progression can be due to the development of one or more known mechanisms of resistance to ALK inhibitors, as we just discussed, and also can be due to the insufficient penetration of the ALK inhibitors into the CNS because of the efflux transporters, as we just discussed. So that is a pharmacokinetic failure leading to the disease progression. So there's how is alectinib different from the crizotinib? So it has definitely got higher selectivity for the ALK when compared to the crizotinib, and it is potent inhibitor of the mutated versions of EML4 ALK fusion protein, which are resistant to the crizotinib, and has got the higher potency. And in terms of the penetration into the CNS, definitely, see, unlike crizotinib and seratinib, alectinib is not substrate for P-glycoprotein and therefore shows the high brain to plasma ratio. So high selectivity, high potency, and works against the resistant mutations which are resistant to the crizotinib and has got good CNS penetration. So the data comes from the data for the alectinib comes from these 4 trials, phase 2 studies, AF001JP, and the phase 3 trials are JLX, Alex, Alicia. JLX is phase 3 study in first-line ALK positive NSCLC in the Japanese population. Alex is phase 3 study global in first-line ALK positive NSCLC, and Alicia is phase 3 study in the patients from China, South Korea, and Thailand in the first-line ALK positive NSCLC. So we will be discussing about the Alex study. So basically, stage 3B or stage 4 NSCLC ALK positive disease according to IHC tests and treatment naive first-line ALK positive. So they were randomized to receive alectinib 600 mg BID versus crizotinib 250 mg BID. So the primary endpoint was PFS, and secondary endpoints were OS and other endpoints. The stratification factors were CNS mets at baseline, presents or absence, Asian versus non-Asians, and ECOG 01 versus 2. So these are the data cutoffs and analysis to date. So basically primary analysis, and then thereafter 3 exploratory analyses were conducted. So if you look at the baseline characteristics, so all the patients underwent tumor imaging at baseline, and it is the first phase 3 trial to prospectively capture the evolution of the CNS disease with routine brain imaging every 8 weeks in all patients while under treatment. So CNS mets, 42% of the patients in the alectinib arm had CNS mets, whereas 38% of the patients in the crizotinib arm had CNS mets. So the updated analysis shows the investigated assessed PFS is 34.8 months with alectinib, whereas 10.9 months with the crizotinib. 34.8 months is roughly nearly 3 years freedom from progression. So that's the final PFS demonstrated that alectinib has the longest mature median PFS of 34.8 months in the first line setting, around almost 3 times the longer efficacy benefit compared with the crizotinib. And if you look at the patients, in the patients of alectinib, 43% of the patients were event-free at 4 years, whereas 4-year event-free rates were not estimable in the crizotinib treated patients. And when we look at the PFS subgroup analysis in the ITT population, it favors alectinib in all the subgroups except for the active smokers. So the magnitude of PFS treatment effect was consistent across all the majority of subgroups, indicating benefit of alectinib over the crizotinib. And the secondary endpoint, PFS by baseline CNS mets. So in the patients with baseline CNS mets, median PFS with alectinib was 25.4 months. That is roughly more than 2 years of median PFS in the patients with baseline CNS mets. And those patients who doesn't have CNS baseline CNS mets, the median PFS with alectinib was 38.6 months. That is more than 3 years of median PFS. And the incidence of CNS progression in the intent to treat population with alectinib, it was 9.4%, whereas with crizotinib, it was around 41%. So hazards being 0.16, there was 84% reduction in the CNS progression with alectinib when compared to the crizotinib. And when you look at the 5-year OS, so alectinib first line has more than 60% OS rate at 5 years. So hazards being 0.67. So that is 6 out of 10 patients are alive at 5 years on alectinib. And 5-year survival rate 62% with alectinib versus 45% with the crizotinib. And when you look at the safety profile, So the median treatment duration with alectinib was 28 months versus 10 months with crizotinib. So there was almost 3 times the longer treatment duration for alectinib. But if you look at the dose reduction, dose interruptions, dose discontinuations, drug discontinuations, so they were similar between the alectinib and crizotinib, indicating that alectinib is well tolerated over the long-term use. And adverse events in more than 10% of the patients in either treatment arm, the safety profile continues to remain consistent and manageable. No new safety signals were observed at the latest data cutoff. So now we have the treatment sequence options for the patients with ALK positive NSCLC. As we can see here, among all the available options, alectinib followed by lorlatinib, so has the longest duration of the disease control, along with a defined treatment sequence, improving the prognosis for this subset of the patients, ALK positive NSCLC. So these are the NCCN and ESMO guidelines. The first line, ALK positive NSCLC, first line ALK TKI, alectinib is preferred. Other agents are crizotinib, ceritinib, and brigatinib, of course, not available. And when patients progresses on these agents, we should see whether it is oligo progression or systemic progression. If it is oligo progression, continue ALK TKI and add on local therapy. And in cases of systemic progression, try to do rebiopsy recommended, not mandatory. But after crizotinib, we have other options like other TKI, other ALK inhibitors, alectinib, ceritinib, brigatinib. And if the patient is exposed to after at least one ALK TKI other than crizotinib, lorlatinib is only the option we have. So basically, alectinib is the preferred first-line treatment option and standard of care because it has demonstrated the longest median PFS, 34.8 months, effectively protects against and treats CNS mets, and only ALK TKI to have demonstrated a clinically meaningful benefit, 5-year survival rate, 62% versus 45%, and it's well tolerated with well manageable safety profile. So with that, I would conclude my talk. Thank you.
Thank you, Dr. Venugopal, for very extensive discussion on alectinib. So I have just one question for you. So let's say there are no financial constraints for all of your patients. Will you start alectinib, or are there any subset of patients in ALK positive patients where you want to do a sequencing?
Yeah, so basically, if there are no financial constraints at all, so definitely alectinib would be my preferred drug of choice as per the data.
So is there any set of patients where you want to use lorlatinib instead of alectinib as a first line?
Lorlatinib, I think it is little more potent inhibitor of ALK. That's what I feel. But when it comes to the sequencing from the data, whatever is available, I think at this point of time, alectinib followed by lorlatinib is also good. That's what I feel.
Yeah, definitely seems logical. Thank you so much for your excellent presentation. So with this, let's move on to the next topic. We have here our faculty, Dr. Preetam Kataria, to discuss about the personalized therapy in the BRAF mutated non-small cell lung cancer. Dr. Preetam Kataria, over to you, sir.
Yeah, at the outset, I thank the organizers for giving me this opportunity. Hope I'm audible and my slides are visible. Yeah. So I will be speaking on personalized therapy to further improve outcomes in patients with BRAF mutated NSCLC. The objectives are to understand the role of BRAF in metastatic NSCLC, gain awareness of BRAF testing methods, and clinical data of dabrafenib and trametinib. And this is the MAP pathway, which regulates the cell signaling from transmembrane growth factor receptors, leading to the cell proliferation. And this is the KRAS, BRAF, MEK, and this is how the pathway is involved in the BRAF mutated tumors. And the incidence of the BRAF mutation in NSCLC is around 2%. So about the incidence, it is 1 to 4% of all the NSCLC adenocarcinoma. And these they did not overlap with other common mutations in NSCLC like the EGFR and all. There are no key characteristic indicators that these patients would be BRAF mutated, unlike the EGFR mutations, where some patients may be more prone to have EGFR mutations. So we know that the most common BRAF mutation is the V600E, which is about 50 to 70% of all the BRAF mutations. And these are the other BRAF mutations which are seen as a part of a BRAF mutation. What we understand is the BRAF mutated tumors have an aggressive histology, and they are associated with worse outcomes with platinum-based chemotherapy, and so there is an unmet need. What we can see clearly in this graph, the disease-free survival is worst in BRAF mutated tumors who have V600 mutations. Also, those patients who have the patients with BRAF but without V600 mutations also fare poor, and they have a poor response to the platinum-based chemotherapy. So approximately 1/3 of the patients remains untreated because 33% of the patients will have best supportive care in the first line. Doublet chemotherapy is the most common treatment options in the BRAF mutated NSCLC. And in the patients with driver mutations, target therapy can help the patients live longer. And this was the treatment algorithm for these patients who were BRAF mutated till now. However, with the broad molecular profiling, we have been able to diagnose those patients who are BRAF mutated, and that is what has been encouraged by the ESMO guidelines and the NCCN treatment guidelines, that the broad molecular profiling should be done in all the patients with NSCLC, also to determine the BRAF mutations. Also, upfront BRAF testing should be done in all the patients because it does not appear to correlate with any clinical risk factors. They have a more aggressive histology, and the BRAF mutated tumors subjected to BRAF targeted agents will do better as compared to chemotherapy or any other targeted therapy. So coming to the clinical data of Rafulnar plus Mexel, that is a dabrafenib combination with trametinib, and it has been approved by the DCGI and the FDA. So what is the rationale for combination of dabrafenib and trametinib? Combination therapy that targets multiple portions of MAP kinase help to overcome the resistance to the BRAF inhibitor monotherapy. So it acts synergistically, it delays resistance to BRAF inhibitors, and it inhibits the cancer growth more effectively as compared to a monotherapy in various clinical trials. This is a landmark study which looked at the combination of dabrafenib plus trametinib. So there were 3 cohorts. It was a phase 2 study. It was a multi-cohort, non-randomized, open-label phase 2 study. There were 3 cohorts. In the first cohort, it included the patients who received the monotherapy. In cohort B, there were pre-treated patients who received a combination, while in cohort C, the patients were treatment naive and they received a combination therapy again. The primary endpoint was overall response rate, while the secondary endpoint was PFS, OS, duration of response. Now, this was the baseline characteristics of the patients in cohort A. See, what you can see is the majority of the patients were adenocarcinoma patients. This was the baseline characteristics of cohort B. Nearly all the patients had an adenocarcinoma histology, and 3/4 of the patients were current or former smokers. If you look at the baseline characteristics of cohort C, what we can see is, again, all of the patients had an adenocarcinoma histology. So this was the trial design, cohort A, cohort B, and cohort C. And if we look at the results, what we can see, those patients who had received a monotherapy in the cohort A, the overall response rate was 33%, and the overall survival was around 12.7 months. If you look at the efficacy results in cohort B, what we can see is the overall response rate was 36%. Sorry, overall response rate was around 63%. And if you look at the waterfall chart, majority of the patients had a partial response. The duration of response was around 9 months. And the progression-free survival was 9.7 months versus 5.5 months. If you look at the cohort C, the overall response rate was around, again, 64%. And if you look at the waterfall chart, what we can see is the majority of the patient had a partial response, with a few patients receiving a complete response. The duration of response was around 10.4 months in the investigator assessment, while in the independent assessment, it was around 15.2 months. If you look at the PFS as the combination therapy, it was double as compared to dabrafenib monotherapy, that was 10.9 months versus 5.5 months. So if you look at the efficacy summary, what we can see is the overall response rate in the dabrafenib monotherapy was 33%. In cohort B with the combination who had received the previous treatment was 63%, and treatment-naive patients receiving the combination therapy had an overall response rate of around 64%. If you look at the cohort A, the most common adverse event was pyrexia, and in cohort B, the adverse event leading to discontinuation was seen in around 14% patients among all the grades. If we look at the cohort B, again, the most common adverse event was pyrexia. If you look at the cohort C, what we can see, again, pyrexia was the most common symptom. So if you look at the cohort A, cohort B, cohort C, the major adverse event was pyrexia. So what is the optimal management of patients who had pyrexia? Was to interrupt the therapy and give first line paracetamol. And if it doesn't respond to acetaminophen or paracetamol, then to consider steroids. And this is the algorithm for the treatment pyrexia management protocol for patients treated with the combination therapy. This is the the chart showing how we should do the dose reduction in those patients who experience toxicities either with dabrafenib or trametinib. What we can see, the starting dose is 150 milligram BD with dabrafenib, and with trametinib it is 2 milligram once daily, and the dose reduction can be till 50 milligram twice daily with respect to dabrafenib, and it can be 1 milligram once daily with respect to trametinib. Beyond this, if there's a dose reduction required, the treatment should be discontinued. So to summarize, the safety profile of the combination was manageable and similar to that previously reported in melanoma studies. The most common adverse events all cohorts were pyrexia, GI-related toxicities, and skin reactions. And pyrexia was the most frequently observed adverse event across all the cohorts. Thank you.
Thank you, Dr. Preetham, for your excellent talk on BRAF inhibitors. So one interesting side effect of BRAF inhibitors is pyrexia. So how do you counsel the patient when you are starting on something, because patients are really concerned about pyrexia, and what are the preventive measures you give to the patient, the suggestions of how to approach you or any hospitals nearby when they have the temperature?
Yeah, so generally I ask them to contact us because many of the outside hospitals may not know how to manage the pyrexia, especially the general hospitals. So we gave a summary to these patients of what should be done in event of a fever. We ask them to first stop the drug, and we put them on paracetamol and report to us so that if the fever also doesn't respond, we can start them immediately on the steroid. But yes, definitely patients are more worried with the kind of fever they get after getting this treatment. Yeah.
Okay, when should we really evaluate for the other causes when the patient is having continuous pyrexia while on this treatment?
So, well, if there are other symptoms, the patient's having cough or having any other, pointing towards infective etiology, in that situation, we should be looking for that. But if the patient is responding to the paracetamol or the steroids, we can safely observe them. And the most important thing is to stop the drug whenever we get a temperature of more than 38.5 degrees Fahrenheit. Yeah.
Thank you so much.
Thank you.
So with this, we shall move on to the next topic. The next topic is about capmatinib, which is a potent and specific inhibitor of MET, which Dr. Sandeep Bhairava, who is assistant professor from AIIMS Jaipur, is going to talk about. Dr. Sandeep Bhairava, welcome.
Thank you, organizers. Let me share my screen. Is my screen visible?
Yes. Yes.
Okay. So let's move. As you all know, MET mutation is reported in adenocarcinoma patients almost 3%, and it occurs mutually exclusive with the ALK and EGFR mutations. In when I count all non-small cell lung cancer patients, it occurs in 5 to 22% of the patients. MET exon 14 mutation are linked to early stage of the diagnosis and predominantly occurs in the older age of the patients. So MET exon 14, these graphs are showing that MET exon 14 mutations are associated with the worse survival. And in a retrospective study, when the capmatinib was not available, a study of 147 patients with MET exon 14 NSCLC patients, 24 patients has received immunotherapy, and the overall response rate was 17% there. The median PFS was just 2 months. The median overall survival was 18 months. So the MET-exon 14 mutation, the immunotherapy is not works well as it works well in the non-druggable, non-target positive adenocarcinoma patients. So MET inhibition prolongs survival in MET mutated stage 4 NSCLC patients. In another retrospective study, patients with mutated metastatic NSCLC patients were treated with MET inhibitor, and it had prolonged the overall survival compared with those treated with the other strategies. Overall survival in the MET mutated stage 4 NSCLC patients was 8 months. For patient who has never received a MET targeted inhibitor, 10.5 months for patient with MET mutation only, and it was 5.2 months for patient with MET mutation and concurrent amplification. 24.6 months of patients who has received MET targeted TKI like crizotinib, glesartanib, and the capmatinib. So capmatinib, it's a selective MET inhibitor. It's an oral ATP competitive, highly potent and selective reversible inhibitor of MET kinase. It has a more than 10,000-fold selectivity for the MET receptor kinase. It also crosses the blood-brain barrier, and its potency can be ascertained with the fact that it has an inhibitory concentration 50% of only 0.6, where the other MET inhibitor like cabozantinib and crizotinib has a IC50 of 720 and 22.5. Now the geometry study. This study was a multicenter open label phase 2 study. It evaluated the efficacy and safety of capmatinib as a single agent in adult patient of stage 3B and stage 4 NSCLC who are aged more than 18 years, who are having any non-small cell lung cancer histology, who are EGFR and wild type, and who are having a MET dysregulation by the central assessment. Various cohorts were included in the study. The cohort 4 was having pre-treated patients with MET-exon 14 skipping mutations, regardless of the MET gene copy number. The cohort 5A was having MET gene copy number more than 10 or more than 10, and without having any MET-exon skipping 14 mutation. Cohort 7 was an expansion of patients with MET-exon 14 mutation, regardless of the MET gene copy number. The primary objective was to ascertain the antitumor activity of the capmatinib while evaluating the overall response rate. The key secondary objective are the duration response. Other secondary objectives were the safety, to assess the safety profile of capmatinib by assessing the adverse effect. And as this table is showing, the pre-treated cohort 4 and treatment naive cohort 5 patients, the median, as I discussed the baseline characteristics of the patient, the median age is 71 years. 58 to 64% of the patients were female. 75% of the patients were having performance status of 1 or better. Smoking history was present in almost 80% of the patients. The gene copy number of 10 or more than 10 was present in 15% of patients in both the cohorts. So in both the cohorts, pre-treated and treatment naive cohorts, almost 95% of the patients have received 1 or 2 prior lines of therapy. This therapy include platinum-based doublet. In the pre-treated cohorts, patient has also received immunotherapy either in the first line or in second or third line. Almost 50% of the patient has received immunotherapy. Clinically meaningful responses were observed in the pre-treated patients, both by the blended independent research committee and investigator assessed assessment. Oral response rate was 40 to 43%, and disease control rate was 78% in both the assessment. Clinically meaningful responses were also observed in the treatment naive cohort 5B, both by the blended independent research committee and an investigator assessment. The overall response rate was more 68%, and disease control rate was 96%. This waterfall plot is showing that the most of the patient achieved a deep response in cohort 4 and in cohort 5B. The median duration of response was 9.7 months in the pretreated cohort, and it was 12.6 months in the treatment naive cohort. Median PFS was 5.4 months in the pretreated cohort, and it was more 12.5 months in the treatment naive cohort. This graph is showing rapid and durable responses across both pre-treated and treatment naive cohorts, with an onset occurring at the time of first tumor evaluation as early as 6 weeks after initiating capmatinib in 82% patients of in the cohort A4 and 68% of patients in the cohort 5B. Capmatinib has also has intracranial response rate. There are 13 evaluable patients with brain metastasis at baseline. 54% of these patients, means 7 out of 13 patients had an intracranial response, and out of these 4 patients has a complete resolution of all brain metastasis. Intracranial responses were as fast as responses seen in the all extracranial lesions. And in the further updated analysis, as I already discussed, the updated results also strengthen the previous observed results. The overall response rate in cohort 5B and further expansion cohort 7 was 65%. Disease control rate was 96 to 100%. In also, it has a high overall response rate and disease control rate in second line or third line setting in cohort 4, and in second line setting in expansion cohort of cohort 6. 44% of overall response rate in all 100 patients. The majority of patients achieved a tumor response at first evaluation after initiating the capmatinib. The response can be seen as early as 6 to 8 weeks. The median duration of response to capmatinib was 12.6 months in the first line. When it was used as a second line, the median duration response was 8.4 months, and the median progression-free survival was 12.3 months when it was used in the first line, and it was 7 months when it was used in the second line. The predominant side effect which has been seen was peripheral edema, nausea, and vomiting in 54%, 45%, and 28% of patients respectively. But the grade 3-4 side effects were seen only in 10% of patients having peripheral edema, and nausea was seen in 3% of the patients.
Dr. Sandeep, can you please conclude? Yeah.
Sir, yeah. So the conclusions are the preliminary efficacy results of expansion cohort 7 are comparable to those previously reported for cohort 5B, both in treatment naive patient with metaxan 14 NSCLC. In pretreated patient, the overall response rate was 52%, and it was 40% in second line or third line. Clinically meaningful median overall survival was 21 months, and it was 13.6 months in the treatment naive and pretreated cohorts. So it has a manageable safety profile, and updated results further confirm that metaxan 14 mutation is a targetable oncogenic driver in NSCLC, and it strengthens the evidence for the capmatinib as a valuable target treatment option for patients with metaxan 14 exon 14 skipping mutations NSCLC. Thank you.
Thank you, Dr. Sandeep. With this, we come to the most important and interesting session of today. The topic is about the landmark real-life studies published in 2021, which have potential impact on clinical practice and guidelines with perspective to lung cancer. To talk in this topic, we have senior-most faculty, Dr. Shyam Agarwal, who is Chair and Director, Department of Oncology, Sir Gangaram Hospital, Delhi. Sir, welcome, and over to you, sir.
So thank you very much for this opportunity, Dr. Venkat and Dr. Sajjan, for inviting me to share some of the thoughts presented at ESMO 2021 and ASCO also. Landmark real-life studies which were published in 2021. Next slide, please. So what is the need for, this kind of a lecture or this kind of, analysis? Because real-world data from, population or institutional level is either collected prospectively or retrospectively. And if the problem is with these trials that you do have more clinical data, but there are less patients, there is more selection bias and usually conducted in single institutions. So when you come to real world, so these become multi-center studies, the expanded access programs, and insurer and provider database or national registries. But then here, the selection bias is much less because you are into real world life, more number of patients, and the clinical data may be less, but then these analysis such as meta-analysis can help us figure out some guidelines for using these expensive molecules when it comes to immune checkpoint inhibitors. Next slide. So as we said, the data from randomized trials is limited, and the idea of these real world data analysis is to answer some unanswered questions and to have some, complementary data on specific populations and monitor quality and outcomes in routine practice. Next slide. So this is what in NSCLC we like to do vis-a-vis the immune checkpoint inhibitors, that can we, get away from chemo IO in patients who are PD-L1 high, from 1 to 49% PD-L1. Can we only get away with IO? What about, specific populations such as ALK, ROS1, MET, etc., elderly, poor ECOG status, and steroids? So, some of these questions we need to answer because we are using these agents and this kind of population in our day-to-day practice. So I'm just going to show you a few slides relating to this kind of specific populations. Next slide. So this is, as I mentioned, is the challenge of selecting pivotal studies from the real world, because as you can see, nearly 80% of these studies are classified as low quality, and therefore, they should not be included. But if you look at the PubMed search in the past year, only in NSCLC, there were 804 real-world studies for NSCLC registry and NSCLC in 203 studies and population-based NSCLC. So I think the objective for this analysis is to select out real good studies who have done proper analysis in the prospective setting, in the real world setting. Next slide. So I'm going to answer some of these questions. Next slide. So the choice of therapy in PD-L1 high, no randomized controlled trials versus, comparing IO versus chemo IO. So I think we are all aware of the studies which have included patients of PD-L1 more than 50% in the NSCLC setting. So these are some of the trials which you are aware of. Next slide. So let us look at the choice of therapy. And if you see from these studies which were real world data, just look at the bottom line. PD-L1 more than 50% was in 428 cases, stage 4 de novo, and initial diagnosis of stage 1 to 3 were 92. So a total of 520 patients. And, chemo immuno was used in 351, and chemo alone or chemo immunotherapy is in 169. So 351 versus 169 patients were taken up from these studies in the, in the large real world data. Next slide. So 351 is mono and 169 is combo. And this is the subset sort of analysis or the demographics. Let's come to the next slide. So you can see here that the overall survival is not different whether the patient got mono or patient got combo, 22 versus 20 months. And if you look at the hazard ratio, which is quite similar, and the p-value is not significant. So, highlighting that in more than 50% PD-L1, so chemo alone is as good as chemo along with immune checkpoint. So immuno alone, basically, the checkpoint inhibitor alone is sufficient. Next slide. And similar data you see here for the real world PFS, that the immune checkpoint inhibitor alone, you see the curves are fairly overlapping and the hazard ratios are just near to 1. Next slide. So this is an interesting slide to show that in a patient who has no history of smoking, we should not be using immune checkpoint inhibitor alone. So because this is favoring the use of chemo immunotherapy combo. So this is a very important aspect. So if you have a patient who is having PD-L1 more than 50% and there's no history of smoking, please don't use immune checkpoint inhibitor alone because that is sort of detrimental. So all other, if you have liver metastasis, no liver metastasis, it is favoring, or it is as good. Immune checkpoint inhibitor alone is as good. So I think that is the take home from this analysis. Next slide. So this is what it says, that PD-L1 inhibitor in more than 50% PD-L1 is likely sufficient with the exception of never smokers. There's not much data on high tumor burden or biology symptoms, etc. So I think there are issues which are lacking, but that is how this analysis stands. Next slide. So what about PD-L1 1 to 49%? And there are no randomized trials comparing IO only to chemo IO. So there are studies for PD-L1 more than 1%, which we are aware of. So let's see what is the real world data. Next slide. When you are focusing on 1 to 49% PD-L1 expression, you see chemo immuno, which is the red line, again is favoring over and above immuno alone. And you see the hazard ratio of 0.68. So this is the overall survival. Next slide. Similarly, the PFS for the same group, 1 to 49%, chemo IO is better than IO alone. Hazard ratio is 0.60. So you're getting a clear indication that for 1 to 49% PD-L1 expression, IO alone is not justified and it should be combined with chemo. Next slide. So you can see maybe patients who are 75 years or older, the hazard ratio is sort of, the same, median overall survival is similar. So there you could consider using, IO alone if somebody is quite old. And similarly, you see in never smokers, you should again use chemo IO like you saw in the previous. So I think barring patients over the age of 75 years in 1 to 49% subgroup, there's a clear indication that chemo IO should be used as a combination and no IO. Next slide, alone. So I think this is the studies are ongoing. In Cigna study, there's a randomized study going on for 1 to 49%, and maybe that data will come through. Next slide. So coming to the uncommon molecular types, next slide. So this is the data for the Empower 150 EGFR ABCP versus BCP. So ABCP is superior, but we know that there are so many other targetable mutations like VRAF, MET, etc. Next slide. And the data there is so small just because the number of patients are small. But look at this summary slide. If you look at the KRAS, BRAF, HER2, MET, so there the 6-month progression-free survival is not too bad when you are using an immune checkpoint inhibitor, to the tune of like 30 months. So here you have, though patient numbers are small, but that is the kind of data you have. So I think the point is, if you have MET, if you have KRAS, or if you have BRAF, So maybe immune checkpoint inhibitor could be considered as a single agent at some point in time after the failure of the specific drug and the chemotherapy. Next slide. So for ALK, I think the results are not too encouraging, and therefore we are not very keen on single agent ICI because the PFS is very, very little. Next slide. In RET, again, you see the response rates are in the first line setting are to the tune of 50%, and in patients who are receiving in second line, 33%. Again, patients are small. So you have a response rate and a reasonably good median overall survival in red. Very uncommon in terms of ability to pick it up. Next slide. So I think there is data for using ICI in specific subgroups like MET and RAF and RET. Next slide. But I think you need more data there. Next. So next is we are all evolving into next generation sequencing at the onset for patients with non-small cell lung cancer. And if you see from 2018 onwards, this is an ASCO 2021 presentation, less than 50% patients are undergoing NGS. So it's not that India is kind of lagging behind. And this is the study from the US. Next slide. So now to monitor the quality and outcomes in routine practice, you can again see here, I think the bottom of this is not visible. There's a difference between whites and blacks, which is statistically significant because of the economic disparity. So these are issues which are being highlighted here, that it is not that in countries like US or Europe, everybody is going through NGS. So there are issues as per the Flatiron Health study. Next slide. So I think the point is that there is a gap between economic status and the application of science as the way we want it to be. But I think people are moving towards NGS for most patients. And this is not only applicable to adenocarcinoma. I think in my practice, since most of us are also looking at other mutations such as BRAF, CMET, and I think we heard in the previous lectures that squamous cell carcinoma should also be covered in those areas. So I think not only adeno, but squamous should also be offered NGS as much as possible, to my mind, to pick up these actionable targets. Next slide. So coming to 3 or 4 specific situations such as steroids and immune checkpoint inhibitors. So if this is the meta-analysis from so many studies, clearly states that overall prognosis of patients receiving steroids for any reason during treatment with ICIs was significantly worse. So I think, and the diamond is towards the detrimental effect of steroids. So I think we must keep this in mind while prescribing ICIs, that not to use steroids. Next slide. And similarly, the PFS, you can see it favors the not using these steroids because there is a 34% higher risk of progression or death. Next slide. Now the PPIs, which are so very frequently prescribed, and they also, you can see here, have a detrimental effect on the outcomes of patients in terms of PFS and overall survival, and therefore avoid using PPIs. Remember that it's very, it's so very, common for all of us to write pantoprazole or rabeprazole, etc. But I think it does interfere in the action of ICIs. Next slide. The ECOG status and ICIs. Next slide. So I think the safety profile was comparable regardless of the PS status, but patients with impaired performance status on average twice less likely to achieve a response. So I think the issue is that the drugs can be used, they are safe, but you may not get that better effect or that good an effect as you would get in a patient population which is having PS less than 1. So keep that in mind while prescribing these drugs. Next slide. So next slide, I think I meant that. And the final is the elderly and ICIs. This is the last slide. If you look at this subpopulation of more than 65 years, and this is the number of patients, large number of patients, But if you were to look at the overall survival, the hazard ratios are quite robust, 0.63, 0.64, 0.45. And mind you, this is a patient population more than 65 years. So don't hesitate for elderly, but they're pretty safe. But in patients who have performance status which is greater than 2, there you may expect a little less response. But avoid using steroids, avoid PPIs, and I think I think this is the real world data from a lot of these studies, and so I think these are certain practical issues which we learn as we keep gathering more and more data in the rare submolecular types also. So with this, I thank you for the invite and the opportunity. Thank you very much.
Thank you so much, sir. This is eye-opener talk in many senses, most importantly with perspective to the drug interactions, PPIs and steroids, which you have mentioned. So I would like to ask one of questions because my place of practice is Assam. So NGS is quite costly for the people here. So can I use Sanger sequencing instead of NGS? I know that the time there is a time constraint, but from the technical point of view, will I miss out of any important mutations? Because Sanger
so
sequencing
actually, for EGFR, people were doing PCRs. So Sanger sequencing is gone out of fashion. And for looking at ALK and ROS1, people are looking at immunohistochemistry as the screening test. So IHC can be used, as a single tool for selecting patients for ALK. But if your IHC is positive on ROS1, then you have to either go for FISH or for NGS. So reflex testing is in order for patients with adenocarcinoma. So these 3 are extremely important. So if you have an adenocarcinoma, a non-smoker, female, and your index of suspicion is very high, then I think you should think in terms of NGS for picking up BRAF or CMET or RET, etc. So I think Sanger is out. Sanger is not being done. So it is PCR followed by IHC in the reflex fashion. If you get something positive, just stop there and then treat that particular actionable mutation at that time.
Thank you so much. Thank you so much.
Thank you.
Thank you, Dr. Venkat, for moderating this the whole journey today evening, and thank you, Dr. Shyam Agarwal sir, for such useful real life insights into the use of IOs in our lung cancer patients. And in fact, one thing which I learned from you is that this PPIs can have an important role, and also for non-smokers, we should not use them. Sir, I'd like to ask you, sir, how much convinced you are with this, that some patients, even if they are more than 50%, they should be combined with chemotherapy rather than IO. So
right. So as I said, I think the current thinking which is going on amongst all of us is somebody has a high tumor burden, somebody is very, very symptomatic. So there, I think the thought process is in order to get an early, response, fast response, and getting symptom relief. So the combination of chemo IO should be preferred, because that is what is not very clear from the real world studies at this point in time. But if you have somebody, elderly, poor performance status, and with relatively, low tumor burden, few symptoms, I think IO scores as good as chemo and IO, as you saw in the PFS and the overall survival data.
Yes, sir. Thank you, sir. And this has been a lovely journey from last 1.5 hours. We've been listening to various speakers today, and we learned a lot from each speaker and also from the panel discussion. And I thank Dr. Shyam sir, as well as my faculty members and esteemed panelists.
Before you end, I must congratulate you and your team for relentlessly pursuing academics on a regular basis, and really standing out really nice and bright here, because it really requires a lot of effort to continue the journey. So thank you very much, and congratulations to all of you for organizing.
Thank you, sir. And sir, also kudos to Venkat, because Venkat is one person, sir, I have always been looking up to him, and he always pitches us. And he is really into academics, sir. That also, I think he is also one of my motivating factor for doing this. And other person is you. Whenever we call you, sir, you're always there to share the knowledge. And that is so lovely, sir.
Thank you.
Lovely, sir.
Thank you, sir.
So Venkat, thank you, and thanks the organizers, Horizon team, as well as the sponsors for today's evening meeting, AstraZeneca as well as Strand Life Sciences. And with this, thank you so much, and have a good night. Bye, sir.
And of course, don't miss tomorrow again. So we are there back again tomorrow with
Oh my God.
exciting sessions. So please invite for tomorrow. So please do join for us. And from all of us, thank you. Stay blessed. Good night to everyone.
Thank you, Tarunji, the real engine behind all this.
Thank you. Good night, sir.
Okay. Good night. Good night.